again may be helpful from the point of view that we can use them for diagnostic purposes. But anyhow, we need to start from the start, from the risk factors, trying to find out whether the patient is prone for disease or not. That again will be quite helpful. That will let us to understand what are the odds for the patient to have atherosclerotic related disease or not. And again, as usual, I'll ask everybody to switch on your cameras in your mobile phones, PCs, tablets, so we'll be able to see you and to control that actually you're attending the class, not sleeping somewhere calmly. Uh, from the point of view of risk factors, it's important to understand that again, if you deal, for instance, with a patient or the male gender of elderly age, in that case, the diagnosis, for instance, of ischemic heart disease will be quite likely. And in many cases, it will be logical and it will be something that will go on along the normal route. So you'll try to adjust patient treatment, you'll investigate patient as usual. If, let's say, you'll deal with a young female patient, in that case, you'll think about anything but ischemic heart disease. It will be the last point that you may be thinking about in the case of different gender and different age. So these two factors may be one of the most important, and you need to take them into account from the point of view of estimation of the, so to say, typical patient with ischemic heart disease. Family history of ischemic heart disease or any other atherosclerotic lesions, or familial may develop myocardial infarction. But fortunately, that happens quite rarely. You'll not have a lot of patients with familial hypercholesterolemia, but definitely those patients will be quite severe, quite dangerous from the point of view of early development of complications of atherosclerosis, and will require all your attention to them. Social class definitely is important, just because social class will determine the patient's lifestyle. Physical load, diet, some other factors that will be related to lifestyle, like stress, definitely may be associated to social class of the patient. And there is so-called term type A behavior, when patient will desire, well, some advances from the point of view of social career, professional career, and in that case, the inability of the patient to fit into his or her own ideal portrait of herself, himself, may result in development of chronic stress, and that may be the risk factor for development of hypertension. That may be the risk factor for constant spasm of coronary arteries, and therefore definitely these diseases, so-called stress-related diseases, will be typically diseases of the patients of type A personality. Those patients who wish to be, well, always at the first rows, who would like to achieve the best. In many cases, that is impossible, sometimes due to their own features, sometimes due to, well, the life that makes impossible that everybody will be the first. And in that case, patient may live all of his or her life in the state of chronic stress. Racial factors definitely is something, maybe the easiest way to assess again genetic factors that will be linked to the rate of development of atherosclerosis. And therefore, for instance, in United States population with the different races living in, well, more or less similar conditions, it's easy to determine that a patient may have some link of development of this or that risk of ischemic heart disease to genetic factors. What may be the well, so-called modifiable risk factors? Because believe me, not always. Well, those factors, it's easy or sometimes impossible to modify. Definitely, cigarette smoking. We all know that cigarette smoking is bad, but typically it's about the risk of cancer. Why cigarette smoking is relevant for ischemic heart disease or for hypertension? Who can tell me? Well, anybody? Um, Maybe Gabriel, Ortman. Well, and it is Jessica. Have you heard that smoking is bad because if you smoke, you'll develop ischemic heart disease or hypertension? Why that?
Yes.
Yes, yes, Jessica.
Because because when we smoke cigarettes, we the level of CO2 becomes higher in our blood, and by definition, ischemic heart disease is when the heart is not receiving enough oxygen and blood supply. So this is controversy with the CO2 intake that we take from the cigarette.
Well, Jessica, well, on one hand, you're right, but I imagine, well, your patient who smoke and who reads some medical literature, and there will be objection to you that if there will be higher level of CO2, there will be hypercapnia that will help to dilate blood vessels. What do you think about that?
Maybe we are talking about other combination between CO2 and nicotine or other components in the cigarette.
Well, you should tell your patient that definitely patient is right, but that is relevant only for the blood vessels not affected by atherosclerosis, because if there'll be atherosclerotic plaque in the blood vessel, blood vessel cannot be dilated because of the plaque that will physically prevent blood vessel from dilation. But point is that smoking will result in vasoconstriction. So if you talk about healthy patient with normal blood vessels, smoking will result in spasm of blood vessels. And on one hand, that spasm may damage endothelial cells. On the other hand, that spasm that will be definitely constant because your patient will smoke, let's say, 20 times per day, will increase peripheral resistance and will result in hypertension that in turn, again, will damage endothelial cells that will much easily absorb cholesterol from the bloodstream. That's why smoking definitely will be the risk factor for hypertension first. And we'll talk about it again in the class devoted to systemic hypertension. And second, even without relation to hypertension directly, due to damage of endothelial cells, smoking may result in progression of atherosclerosis.
Professor, I have a
Yes,
question.
yes, Jessica.
What exactly in the cigarette components will increase the peripheral resistance?
Nicotine. The
Only.
yes, yes.
Oh, thank you.
Uh, um, High cholesterol level. Definitely, that may be due to different factors. It may be definitely something related to patient genetics, and definitely it may be related to patient's lifestyle. So-called Western diet that will be rich of carbohydrates, rich of fat. Definitely, when we talk about atherosclerosis, carbohydrates may be even more dangerous than fat. We cannot eat too much fat, but we can eat plenty of carbohydrates that will stimulate endogenous production of cholesterol in the liver. So cholesterol that will stuck in our blood vessels, that's not rather exogenous cholesterol. Definitely, unless you'll eat well the kilograms of caviar per day. Otherwise, it will be endogenous cholesterol that will be produced if you take too much of carbohydrates. Hypertension, it's important because hypertension will be another factor, independent factor that will damage endothelial cells, increasing the risk of development of atherosclerosis itself. And definitely hypertension, increasing the load to the heart, will provoke decompensation that will develop in these patients much earlier, much easily than in patients with normal blood pressure. Again, obesity. On one hand, obesity is something that is associated to atherosclerosis directly. If you have excess weight, in that case, definitely there will be a high level of cholesterol at this or that phase of your life. Second, obesity will increase demand in blood supply, will increase the necessity to pump more blood, will increase the necessity to increase the level of systolic blood pressure. And again, that will increase demand in blood supply to myocardium itself. And therefore, with the same degree of atherosclerosis in obese patients, there will be much earlier and much more severe manifestations of that degree of atherosclerosis in a patient with normal weight. Diabetes mellitus, extremely important and extremely dangerous comorbidity that will be associated to significantly more rapid progression of atherosclerosis. Again, that will be the topic of our class, I think, at the end of the second next semester. I will talk about the risk of development of so-called macroangiopathies in diabetes patients. And macroangiopathy is nothing else but atherosclerosis. That will be just earlier state that will progress much more rapidly in patients with diabetes than in patients without it. Physical inactivity. It was quite early ago found that even if your patient will take plenty of carbohydrates and fat, but patient will carry out quite intensive physical load. For instance, patient is a heavy lifter, will carry out any regular physical activity on his or her job. In that case, it's not as important as patient that will carry out normal diet, but is physically inactive. So that is important factor, and maybe even more important that patient's diet. A bit later, at the end of today's class, we'll discuss why oral contraceptive pills will be important, to which certain forms of ischemic heart disease and why. What do they do, especially if we talk about early generation oral contraceptives? Same is true for plasma fibrinogen level. It's not relevant for all forms of ischemic heart disease, but only for acute forms. And we already discussed that patient's personality, how patient is capable of resisting stress, or patient is on the opposite prone for stress. That will again result in spasm of peripheral blood vessels that will increase peripheral resistance and therefore will damage endothelium, may be the risk factor for ischemic heart disease, for hypertension. Good. Definitely, we need to calculate risks. We need to find out what will happen to patient in recent life, and therefore there are quite numerous scales that were constructed by a World Health Organization, by some associations, societies of cardiologists, like American Heart Association, and they're more or less same. They take into account patients' diet, patients' physical activity. Definitely, what is very important is body mass index, whether the patient is smoker or not. And something that we need to evaluate using some lab tests, like total cholesterol and patient's glucose, so whether the patient is diabetic or not. And definitely, we need to take into account presence or absence of hypertension. By the way, what is interesting, on this scale, that will represent the ranges of the values that will be the ideal, that will be painted here in green, of the intermediate and high risk, that the smallest range of normal recommended safe will be for patient's diet score. So it's a very easy to exceed that limit and get into the orange or even red zone. So definitely the diet is extremely important. Good. So, by that scale, you may calculate what's happening to a patient. You may predict the risk for development of so-called acute complications, acute states associated to ischemic heart disease, to atherosclerosis. And therefore, from those scales, you may give patients recommendations what to do. Whether the patient should pay most attention to physical activity, restrict patient's diet, whether you should prescribe your patients hypercholesterolemic drugs, increase antihypertensive therapy, and so on. I told you, I think at the first class devoted to cardiology, that atherosclerotic changes are widespread. And unfortunately, at today's class, we are talking about something that is quite deeply hidden inside of the patient's body. These are coronary arteries. Definitely, we can directly visualize them by coronarography. And I started today's lecture with that slide showing presence of atherosclerotic plaque. Here it was in the title slide. But definitely that requires insertion of the catheter in aortic root and direct injection of X-ray contrast substance into coronary arteries. And definitely, patient's myocardium will be far from thankful for you, to you for that. Just because instead of receiving more or less normal amount of blood with oxygen, it will receive some kind of a cocktail with something that may be toxic, that may induce arrhythmias, and definitely will even more decrease the amount of oxygen that will be received by a patient's myocardium. Therefore, definitely, we have for quite a long time methods for visualization of coronary arteries, but those methods are quite dangerous for the patient's myocardium. Therefore, in many cases, we may start from something indirect, looking for signs of aortic atherosclerosis, that will be systemic hypertension, for function of mesenteric arteries, and that again may be much more easily visualized by abdominal ultrasound or by CT, by assessment of what will happen to patients. Cerebral arteries, patient will complain of memory loss. If patient will complain of chilling of lower extremities or some pain at physical activity, that will prevent patient from walking long distance, or maybe that will be systemic hypertension, but it will not be essential, it will not be primary. Is in the case of aortic affection, but it will be directly related to decreased blood supply to patients' glomeruli in the kidneys. Therefore, those systemic changes will be again indirectly, definitely, but helpful in understanding what's happens to patients' coronary arteries. Therefore, if a patient will have typical risk factors, and patient will have typical systemic changes in lower extremities, in celiac artery, maybe upper mesenteric artery, of cerebral arteries, maybe of renal arteries. In that case, definitely the diagnosis of coronary artery disease will be much more likely than without that. Anyhow, according to the definition, ischemic heart disease, the topic of today's class, is only one of the forms of angina pectoris, of coronary failure. So point is that a patient may have other causes of decreased blood supply to coronary arteries. The narrowing of the lumen of coronary artery may be associated to other mechanisms. For instance, it may be related to spasm of coronary arteries. It may be related to thickening due to, for instance, inflammation of coronary arteries, coronariitis. It may be associated to other mechanisms. There may be absolutely normal lumen of coronary arteries, and it will be quite okay with that. But the problem will be with myocardium, that will demand too much of blood. For instance, patient will develop very rapidly a severe hypertrophy of left ventricle. Let's say patient will have valvular heart disease, severe overload, pressure or volume overload of, let's say, left ventricle. And as a result of that, very, very rapidly, patient will develop hypertrophy of the left ventricle, and absolutely normal coronary arteries will be unable to provide enough blood to significantly hypertrophed portion of myocardium. Therefore, we need to understand that ischemic heart disease, when patient will develop atherosclerotic plaque in coronary arteries, is only one mechanism, only one cause, only one disease that may result in development of a syndrome of angina. Therefore, we need to understand so actually what we are talking about when we say the word angina. Angina first is a pain. So if it say that patients have angina pectoris, it may be just a symptom, just pain associated to decreased blood supply. Second, again, angina pectoris may be a syndrome that will be associated to any of the causes that will decrease blood supply to well, the portion of myocardium. And third term that we need to discuss well at today's class is that angina pectoris may be a form of disease. If your patient will have coronary atherosclerosis, in that case, the diagnosis of your patient will be ischemic heart disease, colon, angina pectoris. So in that case, angina will be the form of certain nosological entity that is ischemic heart disease, and ischemic heart disease may be verified by the presence of coronary atherosclerosis. So therefore, if you see somewhere, especially if that will be related to your patient's case record and to your patient's life, your patient's prognosis, the term angina pectoris, please try to understand that it may be three meaning to that word. It may be just a representation of patient's complaints without understanding actually what's going on in your patient's body. It may be indication of just a syndrome, any of the possible causes of decreased blood supply to patient's myocardium or increased demand on blood supply. And third, it may be a certain indication that patients have in coronary atherosclerosis and manifestations due to that. So when we talk about coronary atherosclerosis, we need to understand that there will be certain stages, certain pathological and clinical forms associated to degrees of progression of atherosclerotic plaque. It may be that the first stages are quite thin, almost without a significant change in the lumen of coronary arteries, so-called atherosclerotic streak or atherosclerotic spot. In that case, patient will be absolutely asymptomatic. Then, along with thickening and progression into the lumen of atherosclerotic plaque, a patient may develop symptoms at certain degree of physical load. Typically, your patient at that stage may be diagnosed as having stable angina. But please remember that any progression, any growth of atherosclerotic plaque that may become bigger, bigger, and bigger may be associated to certain degree of inflammation because progression of the plaque may result in damage of endothelial cells, and damage of endothelial cells may be have two consequences. First is inflammatory response by macrophages. Second is recruitment of platelets that may be absorbed by damaged endothelial cells and result in thrombosis. So what's shown here is the end result of progression of atherosclerotic plaque, something that may be in the very, very end of atherosclerotic changes. What do you see here is first atherosclerosis itself. So if you'll pay attention to what's happening here, you may see some kind of needle-shaped crystals. Here they are that are the well, cholesterol crystals. The proof that that is, well, definitely atherosclerosis. That is cholesterol, pure cholesterol crystals here. That is atherosclerotic plaque itself. Again, cholesterol crystals here. And beside that, you may see first presence of thrombosis with organization. So part of the lumen of coronary arteries is already free, it's patent. But there was thrombosis, therefore patient had some acute manifestations. And second, there was another portion, a very thick portion of atherosclerotic plaque, or you may call it another plaque, with destruction and recanalization of that plaque. So you can see RBCs inside. Therefore, a patient developed another lumen, and here I think is another lumen. So patients having three lumen, one that is natural, and two associated to destruction of atherosclerotic plaques and formation of new channels for the blood supply. That's important, and that sometimes make your patient with progression of atherosclerosis sometimes more resistant for issues associated to well, growth of the plaque. First,
Professor,
well, yes, yes.
I did not understand here.
Well, I'll try to show you. So first, progression of the plaque definitely will result in decreased blood supply. And therefore, please pay attention to myocardium that will represent, well, another side of the story, another well, cup of the balances, that definitely, well, with progression of atherosclerosis, will be substituted. So cardiomyocytes will be substituted by fibrosis. There will be fibrotic, yes, cells that definitely will require significantly less amount of oxygen than myocardial cells. They'll not contract. And connective tissue, fibrotic tissue, is most resistant tissue in the body to hypoxia. Therefore, well, first, well, growth of fibrotic plaque means that your patient is living, that your patient is growing older. And the older patient will be, there'll be the less cardiomyocytes and more fibrotic cells just due to patient's age. Second, presence of ischemia will significantly enhance that process of substitution of cardiomyocytes by fibrotic cells, by fibrotic tissue. Again, decrease in demand. On the other hand, a patient may develop with that well progression of atherosclerosis, sorry, recanalization of the plaques and new channels of blood supply to ischemic zone. Therefore, on one hand, there will be some kind of organization of thrombus itself. Second, there may be destruction of the plaques with secondary artificial channels. And on the other hand, the decrease in demand. That's why sometimes patient with the long past history of ischemic heart disease will be more resistant for the new events, acute events that may happen to atherosclerotic plaques than if we talk about a relatively young patient with just well, very onset of atherosclerosis that will just develop some kind of damage of atherosclerotic plaque and a very, very rapid build up of thrombus. There are no secondary channels. There is normal heart muscle that requires plenty of blood. No age-related fibrosis, no ischemia-related fibrosis, and therefore patient's myocardium demands plenty of oxygen and is very sensitive for lack of oxygen. On the other hand, there is no escape for the blood, no other ways to get to myocardium. And another point is that we need to pay attention to is that besides decanalization of the plaque, there may be sometimes anastomosis, some newly developed branches of coronary arteries that again may represent some physiological shunts that will supply blood to ischemic region. That's what I was talking about. Yes, Jabal.
Thank you.
Good. Again, something very indirect, something that will rather represent the higher or lower risk is presence of other atherosclerosis associated lesions like that in patient skin, xanthelasms, or level of patient's cholesterol in the blood nowadays. Again, please remember that patient's cholesterol in patient serum is something that will represent the risk in future. Patient may have extremely severe atherosclerosis, extremely severe, extremely significant damage of coronary arteries or other arteries, and may have at the present time normal level of cholesterol in patient blood. Again, there may be quite prominent affection of skin and now normal level of cholesterol in blood or maybe different degree of atherosclerosis in the arteries. So definitely that's just a risk factor. No direct correlation to affection of blood vessels or level of cholesterol in blood. Something that you see in the skin of the patient is something that was high in the patient's serum. But point is that if there will be a presence of cholesterol lesions in the skin somewhere else beyond eyelids, that is always significantly higher risk of development of atherosclerosis than just xanthelasms. Skin in the eyelids is much more absorbable for cholesterol than skin in other lesions, and therefore, if you see affection by cholesterol, for instance, in the palms, somewhere in the skin folds, like in between fingers, thumb, and finger over patient's joints, that is always significantly high risk of development of atherosclerosis and typically is associated to familial cases than just a presence of cholesterol in the skin of the eyelids. Again, please remember that besides just cholesterol, there may be calcium, and that makes sometimes development of atherosclerotic plaque irreversible by patient's diet or by hypercholesterolemic drugs. Even if it's calcium, definitely it cannot be removed from here by modification of patient's lifestyle or by drugs. That definitely requires surgery, either removal of the plaque if you'll try to pull it away like that. That is atheroma. It's just almost a cast of coronary artery that was pulled out of coronary artery or cut out of coronary artery by surgery. Or application of shunts. If you'll do something, if you'll just modify blood supply by applying some extra blood vessels from aorta to a distant region using patient's mammary arteries or patient's veins, that definitely will work nicely to remove the obstacle that will be located in some proximal portion of coronary artery. But definitely you need to verify that is proximal, that it can be skipped, it can be bypassed.
Excuse me, teacher. I
Yes,
have a question.
yes, Maya, good day.
On the previous slide, what was this picture? Can you go one back?
This one?
No, no, the other one. This
This
one.
one.
What's this?
But that?
This.
This is section of three coronary arteries. This is almost completely occluded, and I cannot see any lumen here, just atherosclerotic plaque and calcium.
Mm-hmm. Okay.
And the other two, definitely there are extremely severe plaques, but about quarter of about 25% of the lumen is preserved here, and about maybe 30% is preserved here. But in all three coronary arteries, there are plenty of calcium. There's plenty of calcium in atherosclerotic plaques. The white substance here is calcium. Calcium that may be visualized nicely, for instance, at CT of the heart, but you may visualize mostly calcium, and unreliably you may visualize the lumen by CT that is definitely non-invasive, but I think I'll show it you later. And if your patient will die, it will be diagnosed just by your ears. So if pathologist will cut coronary arteries, patient's heart, you just will hear some crackling sound. That will be the sound of calcium in coronary arteries.
Okay, thank you, Professor.
Well, and that cannot be diagnosed by clinicians at all. So that can be diagnosed only by a pathologist. That is so-called atherosclerotic streak, and it almost no protruding into the lumen of coronary artery, and therefore even if that patient will receive direct visualization by injection of contrast medium into the artery, you'll be unable to diagnose at that stage of atherosclerosis, well, even invasively, if patient will be alive. So that at that stage will be typically invisible. Anyhow, please remember that still we have risk factors. That's why we counted well everything like that, like patient's gender, patient's age, patient's lifestyle, patient's diet, level of serum cholesterol, and definitely you cannot be sure that your patient is having already atherosclerosis, but you may nicely will predict by the risk factors the possible development of early atherosclerotic changes. And that is definitely a delayed change when you see only well the tiny portion of unaffected artery, that is black, and that is the thrombosis with ulceration, well, opposite ulceration with thrombosis. That is the damage endothelium. That's well, calcium is visible here, and secondary deposition of thrombotic masses that definitely will shift your patient from the chronic stage into acute forms of disease. Well, therefore, what will be the possible manifestations? First, the normal coronary artery will have normal endothelial cells. The patent of the artery, the lumen will be patent. There will be normal endothelium and normal endothelial function, and there will be normal aggregation of platelets. Then, patient with stable angina may also have the patent lumen. The endothelial cells here may be absolutely normal. And fortunately, there will be no aggregation of platelets. Patient will have stable ischemic heart disease. Patient will have symptoms, but symptoms at physical load. There'll be, in that case, no risk for development of complications. At certain type of physical activity of the patient, there'll be no molecular manifestations of the plaque. And therefore, in some cases, we should apply some provocation tests to reveal that physical activity is limited. In some cases, will require direct visualization of the lumen by X-ray opaque methods to say that patient is having atherosclerotic plaque. That stage of ischemic heart disease may be sometimes difficult to diagnose. Unstable angina. Stable angina first means a rapid build-up of the plaque, progression of the plaque from some certain, well, previous degree to some, kind of thicker plaque. And that progression from some previous stage to something, well, thicker could mean that there may be a rupture of the plaque, and therefore it will be associated to aggregation of platelets, formation of thrombus, and there may be some unopposed vasoconstriction at the same time. So that is important, and that may be associated to a risk of acute complications like infarction. Anyhow, well, the progression of the plaque from the clinical point of view will be called unstable angina. First development of angina from zero to something, some clinical manifestations, or from well, one early stage to more progressive stage. And next entity is variant angina. Please pay attention that there is zero atherosclerosis, no plaque. The only mechanism that may result in development of angina, because definitely it is angina, there will be intensive vasospasm, and it may not be related to well, any degree of atherosclerosis. Definitely, vasoconstriction vasospasm may play a role in patients with stable angina, may play a role in patients with unstable angina. But the thicker will be the atherosclerotic plaque, the more widespread, the less will be the role for the spasm. In many cases, patients with intensive vasospasm will have absolutely normal coronary arteries without atherosclerosis. Anyhow, variant angina and coronary atherosclerosis, ischemic heart disease, are different diseases that may be combined in the same patient, but the pathogenesis is different. One patient will have well, spasm as a basic mechanism, the other patient will have, well, gradual, predictable progression of atherosclerosis. Yes.
Professor,
Yes, I'm listening to you.
in the unstable angina, uh, the plaque rupture. Why does it have to rupture?
Because of progression, because it was, well, previously smaller, let's say like that, and then will become thicker. Thicker plaque means that the endothelial cells that will be on the surface of that plaque, these cells will be damaged. The growth. If something will happen to those endothelial cells, and definitely something may happen if plaque was like that, and will become thicker. There'll be damage of endothelial cells, and damage will be associated to development of inflammatory response, and definitely damage of endothelium will result in normal protective response by the platelets, because blood vessel is damaged. Here they are. They are, well, designed, well, to block, well, the possible risk of bleeding. And in that case, instead of, well, saving patient's life from bleeding, they may kill patient because there'll be a buildup of thrombus, and there may be sometimes complete block of the lumen of coronary artery.
But why
So
doesn't
therefore,
accumulate on the rupture, on the platelet?
yes,
Why does it accumulate on the plaque? Why does the plaque?
because the growth, the enlargement of the plaque, that will be rapid, will be always associated to damage of endothelial cells on its surface. Let's say if endothelial cells will cover, well, the plaque like that, and then it will rapidly grow. Definitely, those cells will become, well, distended. They'll become separated. There will be some kind of, well, issues associated to something that was covering the plaque. And damaged cells will induce inflammation. Inflammation will induce, well, aggregation of platelets, like this. Yes, Maya, you also raised your hand.
No, it was for the other question. That's why I raised my
Yes,
hand.
may I ask it.
No, it's okay.
Okay,
I
Jessica, any questions?
Professor, my question is in the variant angina, does the patient show symptoms and how can we diagnose it?
Well, I think we'll discuss it just maybe in a couple of minutes. So it's a very nice question, and it's extremely important. I think we'll proceed just maybe in well, a couple of slides. Good question. For now, we need to discuss actually what is angina. Angina as a symptom, and angina as a syndrome, again, without relation whether it's associated to atherosclerosis or whether it's associated to hypertrophy of myocardium, invalvular heart disease, or, well, autoimmune infection of the arteries. So for now, we talk about symptom and syndrome. No matter actually what will be the disease that will be underlying that syndrome. What will be typical for pain itself? Point is that besides coronary pain, patient with affection of the heart or affection of coronary arteries may have plenty of cardiac mechanisms, but those types of pain will not be coronary. So patient may have cardiac, but not coronary, not ischemic pain. How to understand whether the patient is having something that will not be associated directly to the risk of patient's life, to infarction. Let's say all patient is having angina, and again, no matter whether it's atherosclerosis or not, coronary pain means risk to the patient's life. First is that location will be typical, location will be retrosternal. While in the case of non-coronary pain, pain will be located in the apex of the heart, some closer to the left nipple, to the apex beat. While in coronary pain, it will be typically well located at the center of the chest. Radiation, quite extensive, to the left shoulder, left arm, left lower jaw, left shoulder area. Typically, no radiation or within the chest will be for non-coronary pain. Character, very typical. Most commonly, I think it will be compressing, like viscous, some kind of strangulating pain. Or sometimes it may be burning sensation, especially if patient is having not just attack of angina, but it's already infarction. And something that may be described as acute, like cutting or punching, will be for non-coronary pain. Periodicity, certain attacks of pain will be for angina, may be different and may be variable for non-coronary pain. Duration will be relatively short term, typically 5, maybe 20, up to half an hour. Minutes, if you talk about angina, typically within 2 hours, but that is important if you talk about just angina. If patient is having coronary pain and already developed infarction, patient will have attack that will last for more than 2 hours, but that will be already myocardial necrosis. So if pain will last for more than 2 hours, it's either infarction or something else. And now for provoking factors. For coronary pain, it's important that if we talk about, especially if it's ischemic heart disease, and it's some kind of organic lesion of coronary arteries, and we have some fixed degree of narrowing of the lumen, in that case, there will be predictable physical load that will provoke a degree of myocardial ischemia, and some threshold of pain will be fixed. Let's say a patient will have, for instance, only about 60% of the lumen that will be free, and pain attack will be developed if patient will go up to the third or the fourth floor upwards. That will happen yesterday, that will happen today, that will happen maybe 1, 2, 3 years afterwards. Because that will be the relatively slow process of the growth of atherosclerotic plaque that takes years or sometimes decades. But if your patient will tell you that pain is rather provoked by emotional factors, in that case, it will be very suspicious that pain is related to coronary atherosclerosis. Anyhow, we need to point out that if we talk about syndrome of coronary ischemia in general, not just atherosclerosis, we need to again mention Prinzmetal's or variant angina that you're asking about, Jessica. So if we talk about spasm of coronary arteries, in that case, patient will have ischemia, will have coronary pain, but in that case, rather emotional factors that will provoke spasm of coronary arteries will be relevant. So the most classical situation when Prinzmetal's angina, or it's same as variant angina, will have manifestations is if patient will be sleeping, and sleep is the phase of the patient's activity when there will be enhancement of parasympathetic nervous system action that will provoke spasm. Patient may have a bad dream. For instance, when patient was once a student in departments of propedeutics department and passed exam in propedeutics and failed to pass. So patient had a nightmare. And patient may be awoken by attack of ischemic pain. What will happen? Patient will sit up on the bed, will open the window, will walk just a little bit across his or her flat, maybe even just will walk outside the house, and that small degree of physical load, mild physical activity, may help patient to remove spasm. That is Prinzmetal's angina. On one hand, yes, it is angina. It's ischemia of myocardium. On the other hand, it's very unusual because in that case, physical activity may improve patient state in contrast to atherosclerosis. It will be provoked by emotional factors and may be relieved by physical activity, but typically mild physical activity, because physical activity is something that will be opposite to nightmare during your sleep. Sleeping is parasympathetic phase. Physical activity will decrease parasympathetic, increase sympathetic action, and that's why physical load may be helpful. Definitely, drugs like nitroglycerin, in any case, will help patient. First, because nitroglycerin will be the universal factor that will dilate venous blood vessels. Venous blood vessels, vessels of the greater circle of circulation, is vessels that will deliver blood to the heart from all parts of the body. Through veins of greater circle, blood will go to the right ventricle and then very soon to the left ventricle. So that will be the preload. And dilation of those blood vessels by nitroglycerin will decrease demand in blood, no matter what is the cause, whether it's ischemic heart disease, whether it's valvular heart disease, whether it's Prinzmetal's angina. But in Prinzmetal's angina, there will be another very important point, that besides dilation of the blood vessels, nitroglycerin will relieve the spasm. Nitroglycerin is a universal antispasmodic factor that will, block the spastic action. And by the way, it will be relevant not only for the blood vessels. Nitroglycerin may help your patient with spasm of esophagus that will have retrosternal pain due to affection of esophagus, and spasm may be relieved in the case of esophageal disease by nitroglycerin as well. The basic difference is that the action on veins of greater circle will be rapid, will be within typically 1 to up to 5 minutes, less than 5 minutes. That will be the action on the veins. The antispasmodic phase, antispasm, will occur later. It will be more than 5 minutes, typically 10, 15 minutes. So if your patient will tell you that effect is will start only after 5 minutes, in 10 or 15 minutes, is just spasm, nothing else. It will be early. That will be the effect associated to dilation of veins of greater circle. That will be helpful in all variants of coronary pain, like this. Quite difficult to understand, but that is important, and that's a fact. So if effect of nitroglycerin will develop in late phase, it's just spasm, and most likely it's not the spasm of coronary arteries. If there are issues of coronary arteries, effect will be within 5 minutes. Now staging. Staging will be associated to definitely assessment of patient's initial capacity, how patient's heart, how patient in general is trained. And therefore, the old so-called Canadian classification, when we're indicating, for instance, let's say the patient should walk for more than 5 or 400 meters to get into the first class of angina, or walk, for instance, upstairs 3 or 4 floors, was substituted by New York classification that is significantly less, well, exact from the point of view of measuring the distance, sorry, or floors when patient will go in upstairs, and may look like not as well precise. But point is that if you'll just strictly follow the previous Canadian classification, you may easily mix absolutely different classes of angina because of different degree of physical training of the patient. That's why there are no more meters, no more floors, and in new classification we are using something more gentle, more delicate, and more adapted to patients' typical normal physical activity. So first class is a patient will have no limitation of regular physical activity. Means that ordinary physical activity, and you need it's up to you as a doctor of your patient to find out what is ordinary physical activity of your patient. Will not cause some undue symptoms like dyspnea, palpitation, or especially angina. Second class that was walking up to the distance up to 200 meters in the previous Canadian classification. That means slight limitation. It means that ordinary physical activity may provoke attacks of angina. Third class means marked limitation. It means that less than ordinary activity will be associated to symptoms like angina. And that will be, again, in previous classification, walking up to the distance 100 meters, going upstairs for less than one floor. Patient should stand up and then have a rest. And third class of angina will be associated to rare symptoms at rest. So sometimes patient may develop some symptoms associated to actual absence of obvious overt physical activity. Like, for instance, patient may just sit calmly in the bed or in the armchair, just take food, read newspaper, just move from one side to another side, and that on one hand will be no obvious physical activity, but on the other hand, that activity will be enough to provoke symptoms. And fourth class means that patient typically have symptoms at rest. So patient will be unable to carry out any physical activity without discomfort. Symptoms will typically be present at rest. Please remember that these are the grades. Yes, Jessica, you raised your hand.
Professor, in most of the cases, maybe the patient will not be present when he's feeling all these in our clinic. He won't be always in the emergency room. So in this case, how can we rely on physical activity in order to observe the symptoms that he's experiencing?
You need to ask your patient what happened before patient got into emergency room. That's the point. So you need to find out what happened when patient was on his or her own, and when while patient was walking upstairs or walking across his or her flat or house, and so on. What happened
in
before?
this case, we don't perform the like an effort test. We make him do physical activity in order to see, because
that is another story. You may carry out some provocation test, but that will be the provocation testing. Now we're talking about taking patient symptoms. So just what patient will tell you about his or her normal life and what was the normal life for a patient. Could patient just walk up, let's say, 5, 6, 7 floors, or patient have to rest, somewhere in between, stairs going up one floor. That's the point. Will patient will have still symptoms if patient will be staying in the emergency room in his or her bed, and that means that the patient is having fourth grade of angina or not. So that's the point. And again, you're right that definitely we need to adjust our grade of angina. We need to adjust that to patient's lifestyle. That again may be modified by medical staff, by doctors, by you, including a modification of patient's therapy. So class is not something fixed. Class definitely will be changed, well, both up from the point of view of progression and down in relation to whether patient will take or not proper or well, improper treatment. So that may be modified. And again, that may be not only just well, the indicator of degree of coronary atherosclerosis, but maybe the indicator of well, proper or well, inadequate treatment. Definitely, if your patient will for some time will take medicines and then will decide that patient is well that it's enough to take drugs and will stop taking them, definitely there will be progression from the early class of angina to higher class with no progression of coronary atherosclerosis, just because a patient will stop taking pills. But grading is just well description of the current stage of your patient's well, tolerability of physical load, taking into account patient's degree of physical training, taking into account patient's lifestyle, taking into account certain well, phase of treatment or degree of treatment. Again, from the point of view of talking to a patient, you may pay attention to so-called Levin sign, and patient will clench his or her fist over the sternum to demonstrate severity of pain like this. And here shown in red will be the possible sites of radiation of pain, typically to go leftwards. What will be typical, what will be helpful is radiation will up to the left side of the neck, to the left shoulder area, to the left side of the lower jaw, sometimes left ear. Very, very typical, very classical will be radiation along the inner surface of the left arm to the small finger now. But yes, sometimes radiation may be not as typical, it may go well, rightwards. Sometimes radiation of pain may mimic attack of well, gallstone disease, acute cholecystitis, biliary colic. Sometimes to the right shoulder area. Sometimes pain may have strong radiation well down, especially if there'll be affection of the lower portion or apical portion, diaphragmatic portion of the left ventricle. In that case, pain will radiate well down to epigastric area. Sometimes, by the way, it may be associated to some complications, especially if we talk about not just angina, but infarction. Presence of epigastric radiation or sometimes location of pain may be linked to some ischemic lesions in abdominal cavity, like ischemic ulcer of the stomach or ischemic pancreatitis. Well, what may be the yes, yes.
In which case will the pain radiate to the right shoulder or to the right part of the neck?
It may radiate either there will be affection of the posterior wall of the left ventricle, or sometimes either there will be affection of the diaphragmatic area. Sometimes that happens extremely rarely with the involvement of the portion of the right ventricle. If you talk about infarction, almost left ventricle, only left ventricle will be involved. Affection of the right is extremely rare event. Sometimes if that happens, or if there will be affection of the septum, interventricular septum or posterior wall, in that case, pain will radiate rightwards.
Thank you.
Physical findings. What can we get? Definitely, there may be some issues associated to a decreased systolic function, lower blood pressure, weak pulse, especially weak radial pulse. Sometimes, if there will be a severe decrease in the dilation of the left ventricle, there may be dyskinetic apical impulse. The same may happen in the case of such complication of ischemic heart disease, myocardial infarction, as ventricular aneurysm. Don't forget that left ventricle receives blood from pulmonary circulation. And myocardial ischemia may result in severe pulmonary congestion, sometimes up to pulmonary edema, and that may be associated by rails or by crepitation in auscultation, especially of the lower lobes of the lungs. Patient definitely will develop decreased compliance of the ventricle. And if it will be just a suppressed systolic function, patient may develop third cardiac sound. If there will be also affection of the diastolic compliance, and if it will be difficult for the left atrium to push the blood into left ventricle that have decreased contractility, in that case, patient will develop fourth or third plus fourth cardiac sounds. Sometimes, fortunately, it happens rarely, but it may happen, and sometimes we have patients like those. There may be affection of the apical region, especially of the posterior apical region where papillary muscles are located. And unfortunately, sometimes it may be not just dysfunction, but rupture or necrosis of papillary muscles that may result in severe mitral regurgitation. Well, and yes, sometimes there may be a compensatory overactivation of sympathetic nervous system. Patient will have profuse sweating, diaphoresis. There may be increase in patient's heart rate that may aggravate degree of ischemia even more because, well, the higher will be the heart rate, the shorter will be the duration of diastoles, and myocardium will receive blood only during the diastole, no blood supply during systole. And another problem that may develop will be increase in blood pressure. It happens not in all patients. Typically, a patient will have drop in blood pressure, but sometimes it may happen due to, well, overactivation of sympathetic nervous system, and that is another problem because blood pressure will increase peripheral resistance and will increase demand and blood supply will result in progression of ischemia. So what may be the possible mechanisms and possible manifestations? So pain will be typically severe, very unpleasant for the patient, typically associated to fear of death, persistent, and typically retrosternal. Sympathetic effects besides sweating, cool and clammy skin. Parasympathetic effects, nausea, sometimes vomiting, again, especially if that will be associated to abdominal pain or abdominal radiation of pain. In that case, you'll rather think that your patient may have a peptic ulcer than myocardial infarction. Weakness, again, definitely it's very inspecific, but it may be typically very, very, very severe in a patient. Many patients will have soon after myocardial infarction, at the end of the first day up to first week, some kind of inflammatory changes, most likely it will be just mild fever, but sometimes it may be not just inflammatory, but rather autoimmune changes, so-called Dressler syndrome. Patient may develop fourth, third cardiac sound. There may be dyskinetic bulging in the case of anterior wall affection in myocardial infarction. Sometimes there may be very rough systolic murmur if there will be a ventricular septal defect and there will be shunting of blood from left ventricle into right through destroyed septum between ventricles. Definitely, there may be congestion in electrical circulation. Patient may develop rales. And in some cases, especially if a patient will have involvement of the right ventricle, there may be jugular venous distension. Well, what you may get at some basic routine methods of examination, not much. There may be signs of aortic atherosclerosis, may become more stiff, there may be more intensive shadow, or sometimes there may be deposition of calcium in myocardium that may be visible. These are the coronarograms. Again, that is the catheter in aortic root, and you may see right, left coronary arteries. They are normal, and sometimes you may see atherosclerotic plaques like that, indicating mild degree of atherosclerosis, and that is far from mild. Severe atherosclerotic changes here, the right coronary artery is here, well, very unsmooth coronary artery, with some episode, some fractions of dilation and narrowing with atherosclerotic plaques here. And this is again talking about Prince Metals. That's how properly should well write his name, or just variant angina. When patient will complain of pain, you may visualize coronary artery and see well something that may be atherosclerotic plaque. This well kind of defect, or maybe not. What you may do, you may inject the drug that will provoke spasm, drug that is used, by the way, to treat migraine that is associated to dilation of blood vessels in the brain. Same drug may be used as a provocation test for spasm. And voila, you see that definitely it's not plaque. Otherwise, there'll be no such dramatic narrowing. That is spasm in patients with variant angina. In that case, definitely no surgery is required. Patient will require some mild vasodilators like nitrates that will prevent spasm and will decrease load to the heart. There is a CT, computed tomography, that is non-invasive test, but unfortunately it's very unreliable. Yes, you may may get very, very nice, sometimes two-dimensional pictures as this one, may visualize aortic root, arteries, some narrow sites as shown here, some calcium deposition, but unfortunately that is not enough to plan surgery. Therefore, well, to decide whether patient will require endovascular surgery or not, you have to send patient for coronarography. For ECG, now we don't have, unfortunately, time to discuss in details what will happen and while this will happen at the ECG. Point is that, well, this red curve that is ischemic action potential of ischemic myocardium will first be different from the normal, that is normal. And that difference will be, first of all, in milder changes. So there will be less potential, negative potential in resting state. Instead of minus 80 or minus 90 millivolt, it will be significantly less. Myocardial cell will be less polarized in resting state. And there will be significant less prominent change in charge at activation at the action potential development. And again, there will be less degree of depolarization of myocardial cell. And therefore, we'll have difference in between ischemic myocardium and normal myocardium, both in diastole, as shown here in green, less degree of polarization, and in the systole, and those changes will be opposite. So if we talk about diastole or resting state of the patient, there will be a less degree of polarization, about minus 60 in contrast to minus 90, let's say. And there will be ischemic vector directed towards normal cell during resting state of the patient, or after saying during diastole. So from outside of the cell, ischemic cells will be less positive, normal cells will be more positive. If we talk about systole, that may be most important for us to explain what will happen at the ECG. There will be opposite situation. There will be a vector that will be directed from normal cells to ischemic cells. The charge of the normal cells will be about 0 millivolt during the average duration of action potential, while it will be again on the average about a minus 15 millivolt, and from the outside ischemic cells will be more positive. So that will be the vector of the activation potential during the systole. What you have to remember that the shift of ST segment due to combined action of systolic and diastolic vector will be directed from normal towards ischemic tissue. And definitely the presence of elevation of the final portion of activation, the fourth phase of activation process, total activation of ventricles, whether this phase will be associated to elevation of ST segment or depression of ST segment will depend upon the position of the electrode or lead in respect to ischemic zone. So it may be different. Well, let's say you talk about a patient with subendocardial ischemia. That will be the diastolic vector from ischemic region to normal. Systolic will be from normal to ischemic. That will result in the ECG in shift of the baseline. So we have some kind of the extra field, extra, well, kind of battery that will represent the background for action potentials that will develop at the patient's heart. And this will result in shifting of the baseline. And in relation to that new baseline, there will be some downward shift of the fourth phase of the total activation of ventricles, and our electrode located will close to that area. Let's say it will be the left ventricular lead. Will record decrease of the ST segment, so it will be shift of the ST segment down from the baseline. Again, same location, same lead, but we have subepicardial ischemia. In that case, there will be opposite direction of systolic vector. Opposite shift of the baseline. And on the background, in relation to that new baseline, there will be elevation of that, well, terminal portion of the activation of the ventricles. And your patient in subepicardial ischemia will have in the same leads, in the same location of, for instance, myocardial infarction, will have elevation of ST segment. So that's how we can assess what will happen to a patient with ischemic change, location and type of the involvement. And again, another change that will happen is the change in the T wave, especially its final portion. You may see that the T wave may have some positive elevation, and then the terminal portion of the T wave will become negative. It will be tall, and it will be typically sharp and symmetric. So the descending portion will be symmetric as to ascending portion of the T wave. That is another sign of ischemia in the ECG. Good. Again, that is elevation of the ECG up while T wave, and then you see that the negative T wave will start from its terminal portion. That is from second up to V6, and it's also present in the first standard lead. Sometimes we need to provoke ischemia, and for that you may use some treadmill testing. The elevation of the blood pressure will be used as a measure of physical load, because again, all our patients will have different degrees of physical training. And if at the ECG will record the shift of the ST segment down or up from isolateral line for more than 2 millimeters, in most of the cases, for most of the patients, that will be used as a threshold. So please remember 2 millimeters. It's not always true that there are more complicated definitions if you specialize in ECG, in cardiology. There are special rules how to assess ischemia, but roughly for most of our cases, we can use 2 millimeters, 0.2 millivolt, as the degree of ischemic change. If there will be shift of ST up or down from isolateral line for more than 2 millimeters, that is ischemia. Subendocardial or subepicardial, if there will be shift up in that case. Again, that is the shift of ST segment down post-exercise development of ischemia in most of the left leads. And now we're shifting from chronic phase of ischemic heart disease to acute. That will be acute coronary syndromes, definitely associated to damage of endothelium. So any progression, any change, modification of atherosclerotic plaque, no matter how thin, how flat it was, but if it will grow and if it will grow enough so that patient will be able to perceive that. For instance, patient had no symptoms, and then patient will start having symptoms at regular physical activity. Progression from 0 to first class. That may result in damage of endothelial cell. Damage of endothelial cell may result in development of some degree of bleeding in the atherosclerotic plaque, and then thrombosis may develop. So therefore, unstable angina will always be associated to risk of development of rupture of atherosclerotic plaque, damage of endothelial cells, recruitment of platelets, and development of atherosclerotic plaque thrombosis that may sometimes result in partial, or sometimes, as we see here, complete thrombosis. So almost everything shown here is thrombus, and you may see how tiny is atherosclerotic plaque. It's quite small, and at the same time, it results in complete block of the lumen of the coronary artery, and patient died. So therefore, the first that may be manifested by unstable angina, progressive angina, is so-called vulnerable plaque. Vulnerable means with the risk of damage of endothelial cell on its surface, so growing. That may result in rupture and therefore definitely destruction of endothelium. And from that, it may go to just partial occlusion, or may result in total occlusion of atherosclerotic plaque lumen of the coronary artery. The outcome may be development of severe ischemia with shift of ST segment down, or it may be the case of total occlusion. Typically, that may result in development of a transmural infarction with deep Q wave, and in that case, ST segment will be elevated upwards. Q wave, deep Q wave, the indicator of total transmural infarction, will develop later. And therefore, first marker that may be the marker of possible transmural infarction will be elevation of ST segment up. So you need to pay attention to those patients, because typically they'll have the high risk of severe damage of myocardium. Risk will be higher than depression of ST segment. Anyhow, first what you need to pay attention to is time from onset of attack of pain, and necrosis may start after 20 minutes. So if the time from onset of pain attack will be more than 20 minutes, patient will be at risk of development of myocardial infarction, that is onset of necrosis. And complete necrosis of myocardium may develop in different terms, again, in relation to state of myocardium, state of blood supply, state of anastomosis in coronary arteries. But typically, it will take at least about 2 to 4 hours for complete necrosis of myocardium. So typically, we say we're starting to say that patients having myocardial infarction from 2 hours and onwards. Another important point besides changes in the ECG will be the presence of biochemical markers. There may be different type of markers. We definitely pay attention to elevation of leukocytes, elevation of ESR, but that happens later. The earliest markers will be the myocardial specific CK fraction, creatine kinase fraction, that is will be called MB fraction of creatine kinase, or total fraction of creatine kinase, that will be less specific, and I and T troponins, that will be the proteins that will be released from damaged myocardium. So these will be the earliest markers, troponins and creatine kinase, especially the MB fraction of creatine kinase, that will definitely will be the markers of severe necrosis of myocardium. Later on, there will be elevation of transaminases. First of all, asparagine transaminase, AST, to a large extent, ALT will be elevated. And even later, at the end of about 24 hours, there may be leukocytosis and elevation of ESR. So that will be the terms of elevation of troponin. Troponin will be also important because the degree of troponin elevation will reflect the size of myocardial infarction, so that the earliest event will be the elevation of myoglobin and creatine kinase, and B fraction of creatine kinase, and slightly later there will be elevation of troponin, and it will be different in different degrees of infarction. So, what can we will mention from the point of view of the clinical outcomes of coronary thrombosis? If it will be small thrombus, non-flow limiting, there may be no changes at the ECG, just pain attack in a patient with subsequent healing and gestable progression of the plaque. No infarction. Your patient may have partially occlusive thrombus. In that case, there may be depression of ST segment with or without inversion negative T wave. And if at the same time there will be no elevation of the serum biomarkers, you will say that your patients having just unstable angina, no infarction. Definitely, the depression should be reversible, should improve, typically within a couple of hours. Anyhow, if your patient will have elevation of troponin, creatine kinase, with the depression of ST segment and or inversion of T, in that case, you'll call that your patients have non-ST segment elevation myocardial infarction, small non-transmural. Patient may have occlusive thrombus. If that will result only in transient ischemia, again, even occlusive thrombus may result in non-ST segment elevation myocardial infarction. But if that occlusive thrombosis will be prolonged, that may typically result in transmural necrosis, transmural ischemia. A patient will have elevation of ST segment in that case, and later on, in the case of transmural infarction, patient will have pathological deep Q wave. Q wave that will be more than 1/3 of the amplitude of the R wave in the same lead. Normally, Q wave should be less than 1/4 or equal to 1/4 of the R wave in the same lead. Definitely, patient will have elevation of serum biomarkers, and you'll call that ST segment elevation myocardial infarction. Once again, same point. Most of patients with acute coronary syndrome, with a prolonged attack of angina, will have no elevation of ST segment, and you'll call that those patients will have unstable angina. Anyhow, some of them may progress to non-Q wave myocardial infarction. In that case, there will be again no ST segment elevation, depression, or maybe abnormal T wave. Extremely rarely, these patients without ST segment elevation may progress to transmural infarction. That happens only in extremely small number of patients. If your patients will have ST segment elevation, unfortunately, most of them with ST segment elevation will progress to Q wave, that is transmural infarction. And relatively small proportion will have non-Q wave, that is non-transmural. So therefore, the presence or absence of ST segment elevation will have definitely indirect, not absolute, but high prognostic significance. If there is no ST segment elevation, in most cases, a patient is relatively safe. In most of the cases, it will be just attack of angina, smaller patient, non-transmural infarction, very, very rarely transmural. If there will be elevation, in most of the cases, patient will have transmural infarction, rarely not. That is myocardial infarction. Here it is affection of the anterior wall and septum. Shape of the shift of ST segment is also important. First, we measure these 2 millimeters at the very beginning, at that J point, at the emerging of ventricular complex itself to ST segment, and in that point it should be more than 2 millimeters. And shape is important. In this case of ischemia, it should be typically horizontal. We call that basin shaped, like that, like the profile of the basin, or downsloping. If it will be upsloping, that is not ischemic, it's inspecific. What may happen in non-Q wave, in non-transmural function? Patient may have depression of ST segment, like shown here, ST segment depression. A patient may have negative T, especially its lower phase may become negative, or both negative T and depression of ST segment. And another important marker that you may find out is reduction of the voltage of the R waves. So, for instance, in the left chest lead, you may see instead of total T wave, R wave, sorry, there will be significantly less amplitude of R wave. That will be the markers of the non-Q wave myocardial infarction. Here it is, shift of ST segment down. That will be the one hour afterward. That will be again, depression, quite significant. So what are that? We don't know whether it's infarction, whether it's angina. I have no idea. But this depression persists in 24 hours. So it's prolonged. And therefore, in that case, we can say that is non-Q wave myocardial infarction. So it was not reversed within 2 hours. Anyhow, 1 week afterward, there is normalization of ST segment. It's shifted down, but less than 2 millimeters, and there is gradual restitution of the ST segment to the isovertical line. That is attack of angina, elevation of ST segment, and negative T. Here it is. It is elevation of ST in an V1, in a V2, and ischemic, symmetrical, tall, sharp T wave. It's again myocardial infarction. Transmural. Transmural myocardial infarction means that in your patient's heart will be some area when there will be just dead muscle, nothing, no normal activation, no difference between the ischemic and normal tissue. And that portion of the myocardium, once it will develop, once that portion will become dead, will result in deep negative depression of the ECG. So if you apply electrode directly on the surface of the heart, apply it just on the area of the dead muscle, that electrode from the surface of the heart will result in so-called QS complex. How it will we call that, if this will be the regular ECG from patient's chest. Ischemic region that will be damaged but will not be necrotized will result, again, if you apply the electrode on the surface of the heart, will result in first elevation of ST segment, and then along with normalization resolution of inflammatory response, will result in shift of ST segment down to isovertical line, and T wave later on will become negative. Anyhow, we don't record ECG from the surface of the heart. We record it from the surface of the chest or from limbs. And therefore, in that case, if there will be some distance to the electrode, we'll get a merging of these two patterns. So at the very beginning, once a patient's heart will be necrotized, when there will be already necrosis, from that point of time, you'll get merging of these two times. So already that muscle will give you deep negative Q. Again, deep negative means more than 1/3 of R. And this will be merged to that pattern of the injured muscle. Elevation of ST segment, that's why we're so afraid of that. And formation of the negative T, but just about the very, very final portion of T wave will become negative, or the whole T wave will become positive. Therefore, there will be kind of merging of ventricular complex to T wave, so-called monophasic curve. Well, already after Q wave, there will be elevation of the ECG, and until the end of the T wave, it will not get to isovertical line. Monophasic curve. The acute function, but already after necrosis will develop. And then along with the resolution of the injury of the inflammatory response, there will be again preserved deep negative depression because, well, myocardium will not be rebuilt. It will be just, well, replaced by connective tissue. That will not result in normal activation. Q wave will be preserved and will be preserved up to end of patient's life. But along with the resolution of inflammation, there will be return of ST segment to isolated line, and T will become negative. So again, that is subendocardial ischemia, well, non-ST segment elevation myocardial infarction, small myocardial infarction, and that is transmural ischemia. No necrosis yet. But if we'll deal with pattern like that, when there will be again monophasic curve, ST segment elevation at the ECG, ventricular complex will merge to the T wave that again will become tall, will become sharp and symmetric. That will be very risky of development of transmural function. Unfortunately, most of the patients with a pattern of the ECG like that will develop later deep Q wave, indicating that portion of the myocardium here will become dead. Well, we don't have time to discuss well which lead will correspond to which location of myocardium. We'll have all my slides. I will have the record, and that is important just for our tests and for exam. I will ask you about the location of infarction according to the changes in this or that lead. For now, again, we need to pay attention to some ECG changes. That is normal. That is the acute before necrosis will develop, just ST segment elevation and monophasic curve. And later on, hours up to 1 day afterwards, patient will develop dead muscle, and due to that, deep negative Q with QR or QS pattern without any R wave. And then within days, it will result in numerization of ST segment that will become isoelectric, and T will become negative for many, well, time. So what will happen to T in patients with ST segment elevation function? A tall, sharp T wave, so-called hyperacute phase, minutes after onset of ischemia, just very onset of ischemic damage. No, true elevation of ST. Then minutes to hour, there will be elevation of the ST segment, and here you will get monophasic curve. Risky that is ST segment elevation. And already starting from hours, patient will develop, well, a typical negative Q, pathological Q, deep Q. Days later, patient may still have elevation of ST segment, but already with negative T wave, and Q wave may even increase here when there will be already well-formed fibrosis instead of dead muscle. And then again, Q wave will be more or less same. There'll be normalization of ST segment, and T may become positive days, weeks, month later after infarction. That again, how all events may progress to elevation of ST segment, well, deepening of the Q wave, formation of T, and then just a weeks afterwards, patient will still have the marker of the scar, deep negative Q, and normal the terminal portion of ST segment. That is the acute phase. No yet negative Q here in the second and third chest leads, but already ST segment elevation, tall T wave, and that will progress to deepening of the Q. Again, the monophasic curve, ST segment elevation. Sorry, here it is, and here it is. That is the depression, elevation of ST segment. So different changes of ST segment and different leads. So in that case, we can think that there is transmural function of the left lateral wall. At the anterior wall, we can presume that is subendocardial ischemia. That is already formation of the deep Q wave and elevation of ST segment. 1 hour after attack of ischemia, and then 24 hours afterwards, deepening of the Q, well-formed necrosis, normalization of ST segment, normalization of the T wave, and 3 weeks afterwards, absolutely isoelectrical ST segment and negative T. Same, that is pathological Q, not yet pathological in fourth chest lead, and then a patient developed, well, anyhow, deep Q wave 1 day after attack in lateral wall of the ventricle, septal portion again, very deep negative Q, still ST segment is elevated, and only 2 weeks afterwards, patient developed some kind of normalization of ST segment in the septal portion, and again, less than 2 millimeters shift in lateral left ventricle area. Fortunately, my time is already over, so very briefly, there may be some secondary arrhythmic changes in myocardial infarction, quite different. It may have different causes and may be associated to change in vagal activity or sympathetic activity. They may be associated to treatment of myocardial infarction. And don't forget that quite serious, like atrial fibrillation, like ventricular tachycardia, ventricular fibrillation, disorders may be associated to ischemia of ventricles, because there may be impaired blood supply to pacemakers in the conductive system of the heart. Right ventricular infarction is extremely rare event. Fortunately, it happens rarely. Right ventricle may be rather involved secondarily in the case of destruction of interventricular septum. That is more likely than direct involvement of the right ventricle. So therefore, it's possible, sometimes it happens, but typically there may be rather indirect involvement of the right ventricle. Complications of myocardial infarction may include embolism, both within coronary arteries and along the other arteries for greater circulation. Patient may develop cardiogenic shock due to rapid decrease in contractility, rapid drop of blood pressure. That also may result in decrease of coronary perfusion. There may be arrhythmias, and quite well, commonly, a patient may progress to congestive heart failure. Rarely in the case of transmural or subepicardial infarction, patient may have pericarditis, and typically lethal complication is cardiac tamponade when there will be rupture of the heart muscle, well, the blood will leak in the pericardial sac, and the heart will stop because it will be compressed from outside. Dressel syndrome is some kind of autoimmune response that will develop typically 3 days to 3 weeks after infarction, and along with fever may be associated to some poris rosariis, like pleural effusion, pericardial effusion, and at lab tests typically will have some inspecific manifestations like elevation of WBCs and ASR. Typically, it will be resolved without any treatment. That is another complication of myocardial infarction, development of ventricular aneurysm that may develop early in early phases of transmural infarction or may develop as progression. Fortunately, aneurysm may result in another secondary complication when aneurysm may be filled by thrombus, and again, that may result in embolism to greater circulation. So please be aware of luminal thrombosis of the damaged endocardium. And that's how patient may die just instantly. That is the site of destruction of the ventricle. Blood leaked from the ventricle into pericardial cavity, and well, everything that you see here is a thrombus from the outside of the heart. So patient died. That is acute mitral regurgitation that may develop if there will be necrosis of papillary muscles. Your patient may develop decreased S1 and rough systolic murmur due to necrosis of papillary muscles. There will be incompetence of mitral valve. Another complication that is pulmonary edema. The onset of pulmonary edema just with some kind of shadowing of the roots of the lungs, and that is the almost total, almost complete, shadowing of the both lungs. 4 hours later myocardial infarction. Well, that is all for today. If you have any questions, please ask me, or you may just text me in the chat, and we'll try to discuss them later again. So if you have questions, it's time for discussion. Your tests for? Yes, which system? Whether it's for cardiology, for pulmonology? Everything that is higher than 70% is accepted. Wonderful, it's excellent. That was regular testing, like me asking you at the class, or your teacher asking you during the class. So it's so-called current control. Unfortunately, from now on, all the MCQs, all testing will be shifted only to our educational portal, to university's website, and to our web pages of our departments. For Department of Propedeutics located at Piragovsky Street, at Rosalima Street, and all MCQs will be arranged only in the not in the Google Class, but on the background of the university's website. But there'll be same approach. So if you'll receive, I think, more than 72% of correct results, it will be accepted, and then there will be good or excellent results. Like this, I have no idea about final exam. Fortunately, exam is planned to the winter, so I hope that after the winter we'll be able to discuss all difficult issues associated to testing, to passing the tests for certain sections like pulmonology, cardiology, everything, and we'll be able to practice them just in real life. And there are, I think, there is no chance that there will be online exam. As for those departments who have exams the May or June, they'll have online exam. Well, for us, fortunately, we'll have enough time to compensate lack of practical skills, lack of direct contact between you, teacher, and our patients, real or fake patients. And the exam will be offline, definitely.
Professor, I have another question.
Yeah.
Do we have another topic this semester in internal disease, or
No,
just?
no. This semester is only cardiology.
Yes.
Well, pulmonology and cardiology. Well, second semester will be gastroenterology and something that I call small systems. That will be the blood, endocrine, and the urinary diseases.
Okay.
Therefore, typically you should have two some sub-final tests per semester. For the first semester, pulmonology and cardiology. For second semester, gastroenterology and all those so-called small systems.
And are you going to ask us orally after this semester about pulmonology and cardiology, or how do you want to mark? Like, how do you want to give us marks?
Well, first, definitely we'll discuss both cardiology and pulmonology in the second semester, at least because we need to discuss practical skills.
Yes.
And therefore, I think I will arrange the repetition class to summarize, to have some update. Actually, it was planned just on the regular basis, but I think maybe we will spend more time for repetition. But point is that you should have online testing, online examination for theory in pulmonology and cardiology using our university's website. I don't like MCQs. I don't like testing. I don't like asking student when I don't see student, and I don't like some kind of automatic system of evaluation of student results. but no one is asking me, and unfortunately, no one is asking you. That is a decision of our officials, and unfortunately, there will be, well, the automatic system of marks per section per pulmonology, for pulmonology. It's unfortunately passed, and or we arrange something at the Google class that will be only between me and you, or your teacher if you from other teachers group. And that may be for pulmonology will be decided between your teacher, but for cardiology, everything will be on the website of the university. Everything will be synchronized for all students group, and it will be in the same way for everybody. There will be so-called routine control, as you had for practical skills for cardiology, and same will be after you finalize specialized part when you'll discuss well, instrumental testing. There may be another, well, routine control, again not